the IGC conference, and I'm excited to invite Professor Midday who I think in your programs, I'm not going to, everybody here has very, very distinguished CVs, and so I'm not going to spend time reading everything I have in front of me, but Nidya is Associate Professor of Economics at Brandeis, and she's been doing a lot of work in health and child development and human development in South Asia, and she is also the author of the synthesis paper. So I think what we're planning to do for the session is we have Nidya, who has done in some ways the agenda setting work of writing the review paper, so she'll have about 20 minutes to present. And then we have two very distinguished panelists. We have Shalok Kumar, who's 93 UP IAS officer, who's now the advisor Niti Aayog for health and many aspects of social policy. So he also has a master's in public policy from public administration policy. Public policy, that's right, from the Woodrow Wilson School in Princeton, and we're especially pleased that he's here to present his views both on the paper as well as share broader health-related initiatives that the government is undertaking for which the inputs of this paper would be relevant. And then we are also extremely privileged to have Professor Srinath Reddy, who's the President of the Public Health Foundation of India, who's both been a distinguished career as a practicing doctor, including being the head of the Department of Cardiology at the All India Institute of Medical Sciences, and now one of the leading public intellectuals in the public health, public policy, public finance for public health space in India. And then, I will probably make a few comments of my own regarding the academic contributions, and then we'll try and have a broader discussion.
Thank you all for coming, and thanks to IGC for the opportunity to be here. Okay, so I was charged with the task of writing a synthesis paper on IGC-funded work that had looked at health in India, and so that's what I'm going to share with you today. Let me start by the simple observation to some extent that the relationship between health and economic growth is complex, okay? So in one direction, we have health as an input into economic growth and valued in its own right. But there is also the correlation in the opposite direction, which people have noted regarding the influence of per capita income increases and the impact on economic growth, particularly in the cross-section, and I'll talk a little bit about that. But the point of the paper is to focus on the first pathway, okay, health as it improves economic growth. So when we think about that, there are several channels that we can consider, and much of the groundwork in this area has been laid by David Weil at Brown, starting from the early 2000s. So when we think about, how does health improve economic well-being, he has spoken about it incrementing human capital accumulation, being an integral input to improving productivity, which he terms the proximate effect of health, the direct effect of health. And health is also unusual in that it's multidimensional, okay? So we can measure health in terms of life expectancy, the infant mortality rate, the adult survival rate, and so on. And that makes it a very versatile tool in this basket of commodities when we're trying to improve increases in per capita income, for example. Now, among the channels that I just noted, I'm not going to say too much about the first, which is increases in worker productivity, but the basic insight there is that better workers can only result from the fact that they are healthy. This second aspect about increases in longevity comes from the fact that when the time span for accruing investments, for example, is larger, you have more of an incentive to make that investment, okay? And so if there is a longer time span for which you can make schooling and education decisions, for example, then you see this concurrent increase between these two aspects. And then what has been widely noted is that improvements in health will reduce the disease burden, and that's particularly relevant to India. Okay, this is a graph that has been, so it's from Seema's work, and it has been shown before with David Cutler's work and so on. The point here is that input into any one of these circles has implications for the other two, okay? And so increments to any one of these aspects, whether it's health or labor productivity or income, has spillover effects, and people have considered that and people have thought about it. This is the very famous Preston Curve that talks about the international comparisons between increase in life expectancy and national income per capita. So from this, you should see two things. Firstly, among the lower levels of health, so among poor countries, for example, increments in health per capita will lead to large increases in life expectancy. But among rich countries, this relationship flattens out, right? It's not as clear. And the other important thing is that this holds particularly in the cross-section, okay? So if you follow the same country over time, you're less likely to see this kind of a relationship. Okay, focusing more on the region of India and China, and then I'm going to get to India particularly. This is a graph, again, it's from Cutler from 2006 et al., which on the left-hand side is looking at infant mortality rate, and the x-axis is time. Okay, so you should see two things from the relationship between infant mortality rate and time between India and China. Both of these are declining, right? So that's good. But in China, the decline has been much more substantial than in India. On the right-hand side, it's measuring real GDP per capita, again with time. And again, if you look at the India and China comparison, there's a positive relationship between the two of them. What is more subtle in this graph, and which has been noted much more, is if you look at increases in GDP per capita, for example, in China, the takeoff happened after 1980. Okay? And that's when you see the flattening out of the infant mortality rate declines in China. There's something similar going on in India. The takeoff in terms of GDP per capita happens in the early 1990s after the liberalization. And that's again where you see the flattening happening with respect to successes in reducing the infant mortality rate. And so the argument that's being made, or has been noted by Dres and Sen and so on, is that perhaps there was a redirection of resources away from economic growth, or away from reducing infant mortality towards economic growth, and there is some evidence to support that as well. Okay, let me talk specifically about India based on the three channels that I had highlighted before. So in terms of labor productivity and wages, there is evidence going back for a while, right? That nutrition impacts wages, it impacts labor productivity, fertility. This is especially true in rural India. So Jerry Berman has a body of work on this. Dale Alikar has a body of work going back to the late 1980s regarding this. Some of the things that we want to be careful about when we look at this relationship between nutrition and labor productivity is that asset market inequalities have a role to play here, okay? And so asset market inequalities can exacerbate, in some sense, labor market inequalities. And so this is particularly true where the ability for you to participate in the labor market is driven purely by your nutrition, okay? And so people who have taught, the capacity curve and so on, and from Devraj Ray's book, for example, this will resonate with them. There is also a literature talking about autoregulation, and what is that? Well, this is essentially the ability of the body to adapt in some circumstances to a lower number of calories. And so people have argued that if that's the case, then we are in some sense overemphasizing the importance of nutrition. And what is clear is there might be some autoregulation in the short run, but in the long run, there's absolutely no evidence for that, okay? Okay, so that's on the first one. When we look at the link between longevity and economic growth, this is less clear. Okay, this is less clear in India. So child malnutrition is high, but has been declining. And there's Deaton and Dres wrote the EPW paper in 2009 that opened up this big body of work looking at this aspect. The impact of population growth is important, right? So mechanically, as the number of people increases, per capita income declines, and we want to think about what the implications of that might be when resources are fixed, for example, like land, okay? And agricultural output. And then there is this really nice article by Jishnu Das and Jeff Hammer talking about the quality of medical care, and Karthik has done some work on this area as well, and so you can direct all questions regarding this to him. Okay, and then the last one, which is reducing the disease burden, would serve to liberate resources. I'm going to talk a little bit about the TB burden in India, which is substantial. But others have noted the fact that a big reason for why households fall into poverty is expenditures associated with healthcare. Okay? This is Anirudh Krishna going back to the mid-2000s. In some sense, it's exacerbated the lack of access to quality care. And Dean is here as well, which is talking about sanitation and waste disposal facilities and so on. But what's really interesting is that building these facilities is not sufficient. Okay? And there is a sociocultural argument associated with why that's not happening. Okay, key lessons on health policy. The first couple of these are in some sense different lenses on the same problem, okay? But I needed to highlight all of them. The first one is what is very clear from many of these studies is that resources can have an even higher rate of return if we pay attention to the environment in which these investments are made, okay? And so the way I think about this is that the context matters a lot. So Farzana's work on school, the extension of this midday meal school program, it certainly increased the children's ability to concentrate as evaluated by maze puzzles and so on. But it was these impacts were even higher in schools that were of better quality. Okay? And so it matters in the surrounding circumstances. Arch has some work, and this is just one of them, talking about the adoption of light-emitting diode lighting in firms in Bangalore. And essentially, the temperature, so the advantage of LED lighting is that the temperature on the factory floor is a lot cooler on hot days than if you use the regular lighting, for example. And they talk about the fact that if you don't take that productivity complementarity into account, the amount of time that a firm might take to break even on just the adoption of these energy-saving technologies is about 3.5 years. But once you take into account the production complementarity, that falls dramatically to about 7.5 months. Okay? So there are these additional aspects that matter. Appropriate policies, we want to think about subsidies. And tailor interventions to reflect this. This sounds very simplistic, but and I think Karthik is going to ask something about costs and so on associated with it, but this is one of the aspects that has come out quite clearly. Okay. What is also clear in many of these studies is that it's not the case that more resources are needed. Okay, that doesn't seem to be the case. I think what we need more is more creative thinking on using the resources more effectively. And there is work by Heather Schofield in 2014 talking about the improvements in nutrition and what that has implied in terms of labor supply and productivity and so on. And of course, better nutrition leads to higher labor supply. But what was illuminating from that paper is the fact that many of the beneficiaries have these incorrect beliefs about nutrition. Okay, so they just are not aware of which are the good source products, what's the calorie, energy intake into any of these things, and perhaps just raising that level of awareness will bring about a lot more than, for example, spending more on the PDS system, which we already spend 1% of GDP on, okay, which is a substantial proportion. Okay, there is work by Banerjee and Rohini et al., who are going to be here later, talking about lack of delivery of the public goods on the part of officials. So this paper is very interesting because it talks about urbanization. So this is essentially a survey that was done in the slums of Delhi. Evaluating the provision of public goods, including education, healthcare, clean water, and sanitation. People did not complain as much about education and healthcare as they did about the provision of clean water and sanitation. Okay? And when you dig a little deeper about why this is, again, it's not lack of resources. Again, it's not lack of consensus on identifying what the particular needs are. Again, it's not the fact that these people are just apathetic, not interested. 80% of them are registered voters, voted in the last election, and so on. It's much more just awareness. So, for example, when they go out and do surveys about these, private hospitals and schools in Delhi, for example, have to treat a certain number of poor people for free. And have to treat a number of, educate poor children for free, but nobody knows about that, okay? So slum dwellers, in some sense, don't access the resources that they're eligible for, and when they do access it, they don't access it to the full extent. So there's ignorance about the levels of entitlement and so on, and that's what this says. So I already spoke about the Banerjee paper. Limos and Skur looks at health management in the Indian hospitals. Again, lack of awareness. Not surprisingly, private hospitals do better than public hospitals. But again, if you look at the US, which is the best managed hospitals in the world in their data, Indian hospitals are about 1.8 standard deviations lower, okay? And a 0.8 standard deviation is a large effect. The last one that I want to highlight here is the Coffey et al. Paper by 2015, which talks about religious and sociocultural impediments to the adoption of safe sanitation practices, right? So you can have communities where latrines, pit latrines, etc., are abundantly available, but people will not use it because there are the belief, for example, that having a pit latrine in the household is ritually impurifying and so on. And I'll get to that a little bit more. Okay, so I'm going to skip this. The delivery of broad public welfare services is weak. Absent of take-up schemes is low. I already spoke about Banerjee. I've just mentioned Coffey. I also want to talk a little bit about the Vadera paper from 2016. This looks at municipal solid waste management in Delhi. Okay? And there are these rules that talk about so households are supposed to divide it into biodegradable waste, non-biodegradable waste, and domestic hazard waste. Surprisingly, households don't do that. And so how can we create the right incentives to ensure that they do? So one of the things that the paper considers is just sufficient injection of information enough to change behavior on the part of households? What about if we tell households what other households in the localities are doing? Would that change behavior? And then there is some evidence that it does, okay? It does matter. So having some kind of a community or peer pressure kind of a setup does matter in influencing outcomes when it comes to these issues. Leakage is one of the issues that has come up repeatedly. So there is what are the appropriate policies in this case? There's suggestion of utilizing information and communication technologies in improving, for example, India's midday meal scheme. So this is Sheetal Shekri's work talking about adoption of new technology platforms to look at cost effectiveness of the midday meal scheme and actually just monitoring education and nutrition outcomes. Then people have experimented, so this is Jim Berry's work, with what is the right way to improve nutrition for kids in the midday meal scheme, at the same time reducing leakage. Is it centralizing provision, which essentially means that firms that provide the food are now going to be adding that, so they're looking at micronutrient mix to the thing? Or should we have this in a more decentralized framework with increased monitoring, where you have, for example, the meals coming to the school and the headmasters being involved in adding the micronutrient mix and so on, okay? That's, again, work in progress, but there is some evidence that perhaps decentralization with additional monitoring has more returns. Okay, I want to talk a little bit about this, because it is, in some sense, I don't want to say controversial, but non-intuitive. So culture and religion are factors that we deal with every day in life, okay? And in some sense, these influence the way in which services are utilized and adopted. So the first paper is actually a very interesting paper, looking at the fact, so this is trying to spread information about a health insurance scheme. And what they find is that the agents themselves have preferences about who they want to interact with. So you only want to interact with someone who's socially proximate to you, belongs to your same caste identity, has similar characteristics, and so on. And understandably, that can be a tremendous impediment to the spread of information, and we know that spread of information is important in influencing take-up. So the experiment in this paper is trying to see whether it matters if you bring incentive pay into role when you're dealing with agents, okay? So what's the difference if you move them from a flat pay scheme to one that is a variable pay scheme, where their compensation now depends on the knowledge about the insurance program in a target group that is selected. And not surprisingly, you find that the uptake is much more, the information spread is much more when it's not a flat pay scheme, okay? And so you see these things. Jayaraman, Debraj Ray, and Xingyi Wan have this paper from 2013 talking about gender differentials in eye care. We know much about gender differentials in India. This paper is interesting because the question is do we see these gender differentials because of differences in time to treatment, or do these gender differentials result when we look at medical care in of itself? And it seems as if women are much they take a much longer time to seek treatment for symptomatic eye sicknesses. But once you condition on treatment, there is no difference by gender. Okay, so in terms of time to surgery, in terms of post-operative complications, and so on, there is no difference by gender. And so that paper is illuminating. Jessica Goldberg et al. Had this paper in 2014 talking about TB detection in India. Okay, so Kaivan Munshi has done a lot of work in this area as well. It's a huge health burden in India. Tuberculosis can be, in some sense, debilitating, even if it's not even if it's not fatal. And the question is, how can we increase TB detection, given that it carries the social stigma along with it? And the idea in this paper is perhaps we can use existing TB patients and incentivize them to do something called contact tracing. So they don't directly identify the other person who has, or they do, but then they are approached by the healthcare worker. Okay, and so there is some level of anonymity in this. And then finally, there's this Debnath and Jain 2015 paper talking about the uptake of a health insurance program in Andhra Pradesh. And again, the idea is let's rely on caste networks, okay? Because the conclusion is that the advices that come through a caste chain, in some sense, could be less stigma prone than those that come from outside the caste network. Okay. Appropriate policies. This is slightly controversial, but there's a lot of evidence that relying on age-old constructs like social and caste networks or community and peer groups can increase adoption rates and change behavior in optimal ways. Okay? And so people have done that. People have shown that it's successful. If at the end of the day you want these constructs to decline over time, this might not be the right strategy, but it works. Okay, and then the last thing that I want to note here is we need really good information on what works, and importantly, on why it doesn't and when it doesn't. Okay? So India's flagship RSBY health insurance scheme has only recently been evaluated. One of the things that was looked at was adding on something called a post-health events study to this RSBY. It's actually the International Health Insurance Experiment done by Cynthia Kinnan and all these people. And the idea was, how can we improve the quality of information that's collected here? Okay? What is very clear is that as the recall period increases, measurement error increases as well. And so the idea of the PHES event study, in some sense, is to take a subsample of households, call them up every 2 months, and ask about significant health events like childbirth or an accident, for example. And those households that report having the event are followed up immediately with the questions. Okay? So the total length of time between when an event happens and when the evaluation happens is reduced to about 2.5 months. And what they find is that even in that circumstance, if you ask about things like, what was the out-of-pocket expenditure on health events, there's a lot more measurement error. Or if you look at what's the out-of-pocket expenditure on medicines, there's a huge amount of measurement error. It's much less if you look at time use consequences. So for example, how many days of school and work did you miss? Right? And when people are more likely to report that accurately, especially when it's within this 2.5-month time span. Okay. What do we need to study further? A lot of the stuff talks about increasing awareness on health. What is clear to some extent in India, which is not clear, for example, which has worked really well in countries like Bangladesh, is that NGOs have been less effective in the Indian context. Okay? And this comes across in the Banerjee et al. Paper as well, where the point that's made is that without additional leadership and without additional guidance to NGOs, getting them to, in some sense, transform thinking that has been relevant for a long period of time is going to be difficult. Perhaps it's related to the fact that India is a very diversified society, and so it takes a lot more effort. How do we improve the quality of primary care administered by medical providers? Again, it's not lack of resources, it's not lack of tools or medicines. In fact, the argument that Jishnu Das would make is that this is kind of related to our thinking on education, where we had considered, we want to increase enrollments, and when that's done is now how do we evaluate learning? it's quite clear that people have access to health facilities in India, but the quality of that care is not good. And in some sense, it's being tied, or there is some evidence that it's tied to lack of effort on the part of providers, okay, and absenteeism and so on. Okay, and then, we want a better understanding of demographic transitions and fertility dynamics, the implications of additional population pressures on agricultural security, food security that has implications on, especially when land is scarce and is limited. All right, thank you.